Hello everyone and welcome to Ovarian Cancer Australia's Information and Support webinar. My name is Vanessa Alford. I'm part of the support team at OCA. I'd like to begin by acknowledging the traditional owners of the land that we're on and pay my respect to elders past and present. I'd also like to acknowledge that this webinar is being funded by Dry July, for which we're extremely grateful. This webinar will focus on the sexual challenges and issues faced by women with ovarian cancer and the impact that this has on quality of life. We have three incredible presenters who are going to share some valuable information with you. The webinar is interactive, so over the next hour, you can ask questions to the presenters by using the dark blue hand icon at the top of your screen. Questions will be answered at the end of each speaker's presentation. Please note that presenters cannot address individual medical cases. If you have a particular question, please call the Ovarian Cancer Australia Information and Support line on 1300 660 334. This webinar is being recorded and will be posted on the Ovarian Cancer Australia website. For technical assistance, please phone Redback Support on 1800 733 416. So I'm now extremely privileged to introduce our presenters to you. Our first presenter is Chantelle Otten, Australia's leading psycho-sexologist and sex and relation therapist with a background in sexual medicine and counselling. Chantelle will talk about the psychosexual impacts of cancer on sexuality, its impact on quality of life, and why sexuality is not lost after a cancer diagnosis. Our second presenter is Dr. Janine Porter-Steele, a clinical nurse manager from Brisbane, whose interests are in women's health and wellbeing following a cancer diagnosis. Janine will talk about sexuality, intimacy, and cancer, and will discuss strategies and resources to manage sexual concerns and make intimacy and intercourse more comfortable. And our final speaker is Alissi Jatkafusi, a 27-year-old woman who was diagnosed with stage 3 high-grade and low-grade ovarian cancer in 2017. Alissi had a recurrence in March this year and is now undergoing chemotherapy. She will talk about the challenges she's faced around relationships, body image, self-esteem and sexuality as a result of her diagnosis and some management strategies that she's found to be helpful. So I'd now like to hand over to our first speaker, Chantelle Otten. Thanks, Chantelle.
Thank you so much, and thanks everyone for tuning in. This is a bit of a weird experience to do this via telehealth, but it's really nice to obviously be able to have this kind of information provided, and I'm really looking forward to seeing what the other presenters have to say. So I have way too many slides for my time limit, and I'm just going to get into it. If anyone wants to know what a sexologist does, I come from a psychology background, and I then went on to do my science medicine degree and specialized in sexual medicine. I also became a qualified sexologist in Holland, which is where I am from, and I moved back to Australia about 5 years ago now. So I run a big sexual medicine clinic in Melbourne, and I have 8 sexologists who work there for me, and we love, helping anyone and everyone with any kind of sexual problem, because to admit it, we will all have a sexual concern or a question at some point in our life. So we know that ovarian cancer is kind of up there when it comes to female cancers in terms of the way that it affects our sexuality. We're going to go into it, but we know that it can be extremely devastating. So for 2020, we've seen around 1,500 new cases, and we know that when you get diagnosed with cancer, that is a crisis point. Sex is not something that we're thinking about at that point. If we get diagnosed with cancer, we think about this turning point in our life, and we think about the ways that we are going to have to change from a personal and social point of view, and find adjustments, ways to deal with our new circumstances. How do we restore balance to our lives as well when we have such chaos going on in our bodies? Now, when it comes to cancer, if you have a partner, we also have to look at the problems that might be happening within the relationship, because the partner might start to feel that increased amount of stress. I would feel increased stress if my partner had cancer, and you'd have to look at the change in the nature of the relationship and the family structure alongside the roles that you both play within that relationship. we also have to look at the amount of stress that comes with loss of revenue. So these changes that might happen in a patient's life can essentially lead to emotional distance between couples or however many people are within that relationship, as well as feelings of isolation, anxiety, depression, or inadequacy. 1/3 of partners report that they will also have sexual problems. So we don't really know what that looks like in 2020 because this is a neglected part of research, but essentially there may be a lot of unmet needs, because when we talk to patients, we talk to them about what's going on in their lives. We don't often ask, how's this going within the relationship and how is this going for your partner? There isn't someone for the partner to turn to and discuss this kind of conversation. Sexual consequences, we see that over 90% of people with ovarian cancer will have sexual consequences. I always like to say anyone who goes through cancer will have sexual consequences, and it's about 100% because we know that it's not the cancer that often causes the sexual concerns, it's the treatment of the cancer that causes these concerns. So we have to look at the effects of treatment versus the psychosocial factors that are happening within that patient's life and, of course, within the sexual relationship as well. So we know that from the effects of treatment, we can see a lot of different difficulties when it comes to changes in body image that comes with the treatment consequences, loss of sensation sometimes, definitely a loss of sexual self-image or sexual self-esteem, how confident they feel within that sexual relationship. Maybe they will have disfigurement or scarring, maybe lymphedema, or a change in body parts that might be a very important emotional representation in the mind of that patient. And then, of course, the blissful state of early menopause for these beautiful young women that are having to go through such major changes in their lives. We also know that there can be consequences such as pelvic adhesions as well, which of course makes sexual penetration difficult, painful, and climax may be affected. All of this does not equal an erotic circumstance to me. So I really don't like people to be pushed into this kind of notion that they really should be focusing on their sexuality at this point. We really want to focus on maintaining a sense of intimacy and, of course, having a little bit of fun within the intimate relationship and with the partner. And if there is some type of eroticism that comes with that, great. That's my job to help you with that. So, effects of treatment, radiation. We get pain, we get inflammation reactions on the skin, we get lymphedema, we get radiation damage, we get all of that zapping in the body that really takes away the mojo of the woman. And of course, no one feels sexy when we are so fatigued and also when we might be up all night with insomnia because of the effects of the radiation therapy. Again, not a good mixture for eroticism. Next, we have the anti-hormone therapy. So early menopause is such a life-changing event. Menopause in general is a life-changing event for women, and that's something that I work with a lot in my clinic. But of course, we have the hot flashes, the irritability, the depressed mood, and sometimes we find partners just don't know how to deal with this circumstance. We also find that patients don't know how to express to people, this is actually what I'm going through, and this is why I'm feeling a certain way, and this is why I'm behaving in a certain way. So really a huge part of my job is actually giving that patient autonomy to be able to say, you know what? I'm not my usual self right now. I'm just letting you know and warning people around them, or not warning them, informing them of what's going on in their lives so they don't feel like they have to isolate themselves or minimize themselves to be up to standards, up to society's standards of how you should behave. To be honest, I think it's totally okay to behave a little bit foul during this time. It's really not a pleasant time. We also have the vaginal atrophy. We have painful sex. It's dry. We have a loss of desire, and we have disturbances with the arousal process. So the way that the body responds to, I guess, sexual stimuli. Chemotherapy, of course, not only destroys the tumor cells, but damages all the other tissues with a rapid cell turnover. We have hair loss. We have problems in the gut. We have fatigue. We have weight gain. General well-being as well is a big problem. And then we have, of course, the effect of the hormonal changes and ovarian failure that is caused by the chemotherapy. And most patients say to me, you know what, if desire was like filling up a cup, my cup is completely empty. It's like a well in there. So that's something that we have to work with the partner to let them know this is what's actually going on within your partner's body. We also have to remember that not all of our patients are in a sexual relationship. A lot of them are single as well. So we actually have to be conscious of going, how are you going with this stage of your life? How are you going, perhaps thinking about getting back into the erotic game when you have gone through such an experience by yourself? Is there anything I can help you with? Are you nervous about anything? You know, are there any resources I can point you to? So that's a huge part of my job as well, just giving that person a lot of motivation and confidence to be able to get out on the scene and not worry about the fact that they've gone through this cancer, because we are able to navigate through anything with the right partner. So good questions to ask your patients when it comes to sexuality. What was it like before? Ask them, what was your sexual life like before? What was your body confidence like before? You know, what can we do now with these changes? Were you in a positive sexual relationship? You know, are you single? What about exploring pleasure? What is your background like when it comes to this type of topic? Were you comfortable with it before? Because that will make it a lot easier to be able to discuss these topics post-treatment as well. How do you feel about talking about sexuality? And from my question is, where do you send these women to talk about sexuality as practitioners? And what are the common concerns that you hear from ovarian cancer survivors? So, some thoughts. Once treatment is finished, a lot of these women feel really alone. They feel isolated. A lot of their partners haven't gone through cancer. A lot of their friends haven't gone through cancer. So they feel like they are left alone dealing with these sexual consequences, which are, of course, long-lasting because they've gone through menopause. And, you know, there's often that fear of any type of reoccurrence or relapse as well. Some women are able to return to sexual activity even though they experience a lack of sexual desire or decreased arousal or pain or fatigue. So that's something that me and my team work on. I have a pelvic floor physio that works for me, and we work side by side on treating these patients so they get a holistic approach to their care. Some of these women feel like their partner might abandon them if sexual activity is not resumed. So they might start going ahead with trying penetrative intercourse, which, you know, of course, is extremely painful, and there will be vaginismus sufferers out there, very tight pelvic floors, and a lot of dryness. Others start sexual activity as a way of expressing affection and maintaining intimacy in the partner relationship. I like to tell people to go and have more outer course. For a simple way of putting it, of course, this is a bit of a process, but outer course is any type of sexual play that is on the outside of the genitals. So we also found that partner initiation of sex predicted a greater marital satisfaction for some patients. But when we look at the partner, we know that most partners actually don't know how to approach the subject of touch or sex after breast cancer or ovarian cancer, and may be very confused about what to do next, especially with all these changes that have gone on in the patient's body. So partners struggle to know how to support, but also demonstrate love, also demonstrate desire. I see you, you've gone through cancer, I still love you, I still desire you, I still want to be in this intimate relationship with you, but we need to figure out a way that we can navigate that together. And then there are fears, of course. Will I harm my partner? Will I add pain? And spouses may feel neglected or rejected and may temporarily lose their connection. So we try and aim to getting partners to turn towards each other rather than away. So for patients, when they come in to see you, they're very scared to start talking about sex, and 85% of them will not start that discussion. So that means it's your job to be asking them about sex. And in a study, we found that 62% of women with gynecological cancer had not been asked about sexuality at all. And I think the problem is that sometimes we know, well, not sometimes, we know that there are barriers to addressing sexual health needs in practitioner sessions. because a lot of practitioners do not see it as part of their role. There might be environmental or system issues. There might be a lack of knowledge and skills. Sometimes we have to look at our own attitudes, our own values and beliefs as well. And then confidence and comfort and positioning sex as irrelevant or inappropriate for some people as well. So when you're talking to your practitioner, we have to remember that for you, sexuality is a really important aspect of general well-being. It has benefits on cancer treatment. It is a multifaceted construct. And of course, we don't have to be having penis in vagina sex for it to actually be sex. So I think that we need to remember, for anyone, sexuality is a huge part of their life, and it's very important for you to be able to go, you know what, I deserve to be having a sex life that suits me and my current circumstance. My job as an onco-sexologist is to increase awareness, to look at a new set of skills and facts, to look at a different attitude for you, and also help with treatment skills and try and work as a team. This is my pelvic floor physio. He's going to help with any pain that's happening down there and any discomfort. And we work side by side to be able to make sure that you feel confident coming back into the sexual game. And here in my sessions, I really talk about how we restructure the sexual script. So the script is kind of like the menu that you follow when it comes to sexuality. And I help you focus on a new me and a new we as a couple. We also look at medications that you're working with, sexual tools and toys, any type of vibrators, homework, lubricants, how the relationship's working, alongside just normalizing your concern and having a little bit of fun. I can imagine that after cancer, we need to make sure that we're having a lot more fun. Okay, so thank you so much. Are there any questions?
Thank you so much, Chantelle, for that extremely valuable presentation, about a topic that I think a lot of people find very difficult to talk about. There is just one question. Someone has said that, I feel that myself and my partner need to see someone like you because we are having a lot of challenges, but my partner is reluctant. Do you have any ways that, how I could convince them to come and see you?
The first thing is, why don't you come in for a session and we work it out together? It's the case for a lot of people that they don't know how to get their partner to start. But essentially, if we lead the way, often our partners will follow. And if they start seeing that you're coming in with new tools and new ways of communicating with them about these needs, then we can do that. The sessions that I hold are hands off. We're sitting there, we're problem solving, we're talking through it, and we're making sure that we're coming up with the right solution for you.
Great, thank you. Very valuable advice. Thanks again, Chantelle, for joining us on this webinar. We really appreciate your time.